So, welcome. This is my assessment for STC-Y03, the muscular joint assessment. And the joint that I have been chosen to assess or evaluate is the ankle joint. Before I go any further, health and safety has been considered. I've taken off all my jewellery and I've washed my hands thoroughly. Contraindications and red flags have also been discussed with my client, and she has nothing that could adversely affect the treatment. So she is happy for the assessment to take place. So the first thing I'm going to test today will be gait and the pattern of movement. After that, I'm going to check range of movement. So I'm going to check it actively, passively, and with slight resistance. Then I am going to clear the joints, and then I'm going to test the integrity of the bones, muscles, tendons, and ligaments of the ankle. I have chosen 5 special tests today to conduct towards the end. They are the anterior draw test, the posterior draw test, the Taylor tilt test, the syndesmosis test, and the Thompson test. So now we will begin the examination. I will start by saying that my client has informed me that she had peroneal brevis surgery on her right ankle. And for me, that could be a sign or a reason why she's still getting pain in her right ankle. So I'm obviously going to assess the right ankle further because there's more pain. So the first test we're going to do is a basic gait cycle analysis, and I'm just going to have a little look at the muscles and her feet as she walks. So there is a difference between walking and gait. Walking is the whole movement combined, whereas gait is the pattern of movement. So the lifting up, putting down, and the whole pattern of movement. So I'm just going to get my client to come in, and she's just going to walk up and down, and I'm just going to tell you what I'm looking out for here. So if you'd like to come in and just walk up and down for me. So as you can see, my client turns her feet out quite slightly and she walks quite heavily on her heels. But now I've mentioned that, she has actually just changed the way she walks. And that's probably because I've just mentioned it. I have got a pair of her shoes down here. If you'd like to just stand in front of the couch, that would be great. I have a pair of her shoes here that you probably can't see, but she doesn't have a lot of grip left on the heels. And she's had these shoes for 3 years, and she wears them to work, and she wears them very regularly. So as she was walking, I couldn't really see from here whether or not there was any muscle imbalances or muscle bulk differences. So I'm just going to have a feel. I'm now going to have a closer look and feel tibialis anterior and posterior on both legs, the gastrocnemius and the soleus and the Achilles tendon. I'm just going to have a look at the foot itself, and I've noticed that I can't fit any fingers underneath her arches. So that suggests to me that she has quite flat arches, which could be, there could be many reasons why her arches have collapsed like this. I can feel she's quite tight on her right leg. The reason I'm checking these main 4 muscles is because the gastrocnemius and soleus are the prime movers of plantar flexion. So if you can just go onto your tiptoes for me. So that's plantar flexion, so, and then come back down. And they're the main drivers of that. So if you could just go into dorsiflexion for me, so just stand on your heels. So the main muscle here is the tibialis anterior, and yeah, if you'd like to go back. So yeah, like I was saying, with plantar flexion, it's the gastrocnemius soleus, and it includes the Achilles tendon because that actually inserts onto the calcaneus at the bottom of the foot there. So now that my client's on the couch, I'm going to start by clearing the knee, and then I'm going to clear the toes. So the reason we clear joints is to see if the symptoms are coming from the joints that we're clearing. And it also serves in validating that the pain is coming from the right area. So now what I'm going to do is I'm going to do knee extension. So if you can just extend your knee as much as you can, so like that, and then I'm going to apply a bit of pressure just to try and take it outside of its normal range. So does that feel okay? Mm-hmm. And I'm just going to do the other side as well here. All right, now we're going to clear the knee in flexion. So with clearing the knee joint, it's an active movement with slight overpressure from me as the therapist. So if you can bring your leg into flexion for me. So is that as far as you can go? Yeah. So then I'm just going to add a little bit of overpressure. See if I can take your muscles to the point of bind. How does that feel, all right? Mm-hmm. Yeah, perfect. So I'm now going to do the other side as well. So take it into flexion for me. Ideal. And then, is that right? Mm-hmm. Lovely, no problem. So now we're going to test internal and external rotation of the knee. Again, as part of the joint clearing. So what I'm going to do is inwardly rotate the knee. Does that feel okay? Mm-hmm. Yep. And outwardly rotate the knee. Does that feel all right?
Yep.
And the same on this side. I feel all right?
Mm-hmm.
And then the same on that side. All right?
Mm-hmm.
So, lovely. As my client's in this position, I'm going to look at clearing the toes. So, again, this is an active movement with slight overpressure. So, if you could flex your toes on your right foot by tightening them up for me, please. And I'm just going to add a bit of overpressure. Does that feel okay?
Mm-hmm.
And then extend your toes for me. How does that feel?
Mm-hmm.
Yeah.
Fine.
And then the same again. So flex your toes. Does that feel all right?
Mm-hmm.
And then extend your toes. Feels all right?
Mm-hmm.
Lovely. So because you're sitting there, I'm going to have a palpate and I'm going to feel the bones, the muscles and the tendons. I'm here to check basically if there's any swelling, pain, tenderness or increase of heat. An increase of heat could be down to acute inflammation. So I'm just going to have a feel with the back of my hand to see if there is any heat on both sides, which there isn't. So I'm now checking the medial and lateral malleoli of the tib and fib. I'm also checking the bones of the foot. So I'm checking the calcaneus, the talus, the cuboid, the cuneiforms, the navicular, and the fifth metatarsal, as well as the other metatarsals, just to check if there's any pain on palpation or any tightness. So this is the uninjured leg. I can't feel any tightness here. Now I'm going to check the ligaments. So I'm going to check the ATFL, the PTFL, and the CFL. How's that feel? All right?
Mm-hmm.
No problem. So just moving medially, I'm going to check the deltoid ligament, which feels fine, and the Achilles tendon. Right, yeah. Now I'm just going to check the other side. So I'm just checking the medial side here. The deltoid ligament feels fine here. Let's check the bones as well. Yeah, and now I'm just going to check the ATFL, the PTFL, and the CFL. How does that feel? Is that all right? No pain or anything?
Bit sore.
Bit sore, yeah. In where my finger is here, where my
Yeah.
thumb is.
Yes.
Yeah. No problem. Now I'm just going to move up slightly and feel the syndesmosis joint just above the talus, just to check and see if there's a high ankle sprain. Does that feel okay?
Mhm.
Yeah. I'm just going to do on the other side as well. That all right?
Feels a bit sore.
Feels a bit sore on that side as well.
Mm.
Okay, no problem. Now I'm going to conduct range of movement tests. I'm going to do range of movement 3 times, once actively, then I will do it passively for the client, and then the client will do it actively but against resistance. First of all, we're going to start with dorsiflexion actively, so if you can just point your toes in the air for me. Is that all right?
Mhm.
And then plantar flexion, so point your toes down.
Mhm.
And inversion, so toes in, and eversion, toes out. How did that feel? Was that all right?
Fine.
Yeah? Okay, now I'm going to do range of movement passively on the uninjured leg, and then I will do it passively on the injured leg. So I'm just going to bring it into dorsiflexion. All right?
Mhm.
And then plantar flexion, and inversion,
Mhm.
and eversion. Does
Fine.
that feel okay?
Mhm.
I'm now going to do the other leg, but whilst I do the other leg, I'm just going to mention some averages for the movements. So they suggest that for plantar flexion, the average is about 50 degrees. The average for dorsiflexion should be about 20 degrees, which that looks a little bit less than 20 degrees by my eye. And the average for inversion of the foot is about 35 degrees, and the average for eversion of the foot is about 25 degrees. If you can go over this range, there could be a couple of reasons. It could be ligament or tendon laxity, damage to the tendons, or even hypermobility of the ankle. The last range of movement test, where I'm just going to get the client to do the range of movement exercises actively, and I'm just going to use my hand to apply a bit of resistance. So I'll start with the left foot. So if you can dorsiflex your foot for me. Keep going. Is that all right?
Mhm.
And then plantar flex your foot. All right?
Mhm.
And evert your foot. So that way. All right?
Mhm.
And same again. Invert. I'll just do it on the other side as well. So dorsiflex, so toes to ceiling, yep. And plantar flex. So inversion and eversion. Does that all feel okay? Now I'm going to do the special tests that I spoke about at the start of the assessment. The first test I'm going to do is the anterior draw test. So what I'm doing here is testing the mechanical stability of the talocural joint and the integrity of the talofibril joint. A positive result to this test would be a weakening of the end feel or a weakening of the elasticated feel. So the next test I'm going to do is the posterior draw test. So it's very similar to the anterior draw test, except rather than pulling up from here, you're pushing down from here. Primarily, this test is used to determine whether there is a posterior talofibril ligament injury. Now, this test is a talar tilt test. So what I'm going to do is I'm going to put the foot into eversion and slight dorsiflexion to see if there is any pain or any laxity in the CFL. So how is that?
Mhm.
And I'm going to do the other leg here. So yeah, it is said in literature by Barr et al. Published in the Study of Mechanics of the Anterior Draw Test and the Cadaveric Study of Lateral Ligament Injuries, page 435 to 441, that if an injury has happened to the lateral ankle, the ligaments could be lax and increased inversion may be present. This test is the syndesmosis test. So if you can bring your leg into flexion for me at the knee, so like that. And I'm going to find my hands halfway up the tib and the fib, and I'm basically just going to squeeze and see if there is any pain radiating from the distal end of the tib and fib. This would indicate that there has been some kind of fracture or injury to the syndesmosis joint. So I'm just going to do that one now. Does that feel okay?
Yeah.
And then if you put that one down, I'll just do the other leg. So, yep, perfect, thank you. Is that all right?
Mm-hmm.
This is the last special test that I'm going to be doing today, and it is the Thompson squeeze test. This is designed to check out the structural integrity of the Achilles tendon by squeezing the gastrocnemius and the soleus. And with that squeeze, you should see plantar flexion in both feet. So I'm just going to do that with my client. So as you can see, there is plantar flexion there. If you can just move that leg up like that, I'm just going to do the other leg here. So as you can see, there is plantar flexion. I'm going to be doing one functional movement test. I've chosen standing on tiptoes test. If all goes well, so if you can just go onto your tiptoes, if all goes well, if you just stay on there like that, is that comfortable?
Bit sore on the right foot.
Bit sore on the right side. So if you go down, I'm just going to get you do it once more in a second when I say so. Really, what I should see is an increase in the client's arch as she goes up in the up movement, and when she's on her tiptoes, I should see very mild supination. So her feet should turn in, and again I should see similar plantar flexion on both feet. So if you can just go up for me, so, and then come back down. This is interesting because my client can't hold this position for a long time and she can't control the movement very well. This shows me that there may be instability in this right ankle from her previous ankle sprain and ankle operation. So now we finished the special test and the examination. I'm just going to do a brief summary of the results that I found. Obviously, I haven't had time to write down and assess all the information that I would have done if this was a professional clinical assessment. What I did find was during the Taylor tilt test, my client did complain of quite bad pain coming from her lateral ankle. And to be honest, she had told me prior that she had had a brevis injury on her right leg. But her CFL and PTFL were also very tight.